Hey everyone, welcome to the last session of the POCUS Training Academy. Thanks for putting up with us. Totally appreciate it. Hope you're viewing this at home. This is a really short lecture. Hopefully you can bang it out in like 20 minutes. I'm going to share my window so you can sign into ease real fast and get your credit. I did the rush exam, but I forgot that Dr. Felice had given that already. So just soft tissue real fast. Give you guys a minute to grab that and get logged in. All right. I'm going to jump to our next screen. And hopefully you guys can see my screen. I'm just gonna log in for a quick second on another device, and I just really want to make sure that I don't have to re-record this. Maybe, maybe not. Don't think you guys are seeing my screen. Sorry, troubleshooting, bear with me. You can skip this part. All right, Teams and I are not friends. I apologize. All right, let me figure out how to share this. Screen. All right. Great. You guys should see my screen. Unfortunately, my mouse doesn't show up on my computer, so you're going to see the side of my head for a part of it. All right, cool. So real fast. So 99% of your images are going to be taken with your linear probe. Again, it's a superficial, it's skin. Very, very rarely you might use the curvilinear if you're like down in the thigh or trying to see something a little bit deeper. So when we look at our soft tissue, you essentially want to think of it as like a lasagna, right? So there's a couple of different layers. So you have your superficial, like dermis, epidermis layer. Then you have your subq, which is kind of your fatty layer, then your muscle, and then your bone. And one of the things I want you guys to really start to hone in and pay attention to is going to be this layer right here, which is your superficial fascial layer. And we talk about non-necrotizing soft tissue infections in a couple of slides. This layer is going to start to become really important. So again, epidermis, subq, muscle, bone. Ultrasonographically, you're going to have your epidermis on the top, your subq, your superficial fascial layer, and then your muscle. So we're just going to come back. And so this is what it looks like. So muscle looks kind of nice and striated, just like marbling on a steak. Here's your bone. Again, this is that important layer you want to look at when it comes to cellulitis and NSTIs. This is your sort of subq layer, which will become important when we talk about cellulitis. All right, so skin. So the first thing I always like to ask, right, POCUS is kind of your physical exam on steroids. So we're asking very simple kind of yes/no questions. POCUS will never tell you, is this cellulitis or not? Because things like lymphedema and pedal edema from CHF are all going to look the same as cellulitis. So you can't use it to figure out cellulitis or not. But what you can do is look for the severity of the cellulitis, look for complications like an abscess, and look for things like necrotizing soft tissue infections. So how do we do it? So again, your linear probe, again, you're putting the probe on cootied skin, so just try to make sure that you cover it, both to protect the probe and to protect the patient. So the first thing you want to do is, I always like to start in long axis. For me, that's kind of a easier thing for my eyes to kind of process because the muscle fibers are nice and long and continuous. But if you notice, right, there's no sign of infection where I'm scanning here. And so you always want to start far away from the area in question or the area of cellulitis. And it's a couple of reasons. One, it lets your eyes kind of adjust and focus on what's normal versus kind of just plopping into the middle of abnormal, and it might be a little disorienting. Two, it gives you an idea of sort of where does that line start of where it goes from normal to abnormal. And three, if you plop the probe where it hurts the most, right, that patient's going to probably punch you and not let you go near them again. So if you can start further away where it doesn't hurt and then slowly start to get to the area of pain, they're going to tolerate it much better. All right, so what does cellulitis look like? Well, the first thing you're going to see is that fascial layer is going to actually, sorry, not fascial layer, that sub-Q layer is going to start to thicken up. The next thing you're going to see is normally that sub-Q layer has beautiful architecture. It's bright whites and it's darks and it's blacks and it's gray, and there's all these sort of lovely different interlined, like kind of lacy pattern. And when you start to get cellulitis, it just starts to look gray. So we call it homogenization, or that loss of architecture. And then the last finding, or the latest one, is cobblestoning. So this is a more kind of developed or more chronic infection or more severe infection that's been going on for a little while. And cobblestoning is essentially just looks like cobblestones on a street, where you get edema in that's kind of sneaking in between the layers of fat. And so the fat ends up into the stones, and then the edema is the like mortar or the cement in between the fat lobules. So on this one over here, you can see normal. So all this kind of beautiful architecture that we talked about, there's that superficial fascial layer. Here's your epidermis and dermis. And then if we go to the abnormal, right, this starts to thicken and it starts to look gray and more uniform. So again, here's another example. Normal, as we fan through, lots of different bright whites and darks and grays and lots of architecture. And here is just sort of angry and uniform and gray looking. So if we come to this one, this was a patient that came in with a cellulitis over his elbow. And again, you can see kind of gray, it's angry, that's a blood vessel right there. You can start to see some cobblestoning. And then this is that superficial fascial layer. And here we can appreciate that muscle, the striations of the muscle. As we're going kind of closer and closer to the area of where maximal infection is, now we're starting to see a lot more cobblestoning. We're seeing the fluid tracking pretty deep, right? And it's tracking right along that superficial fascial layer. So it's going to become really important in a couple of slides. And then you also start to notice there's a little bit of fluid kind of tracking deep to that fascial layer. Again, also going to become really important. So remember this slide, and we're going to come back to it in a minute. So again, early is uniform, homogeneous, thick. Late is when you start to get your cobblestoning. That's when you start to see the fluid tracking in between those fat lobules. One of our pitfalls, though, right, is lymphedema and pedal edema from like nephrotic syndrome or cellulitis, ascites, volume overload. They're all going to look the same. Again, here's edema tracking in between those fat lobules. So you can't use ultrasound to say cellulitis or not when you're looking at like venous stasis or lymphedema. It's going to be that clinical context. So just to recap, so mild cellulitis, you're going to have loss of architecture, you're going to have cobblestoning, and then you're going to have the sub-Q thickening. As you go from mild to more severe, you're going to start to see signs of NSTIs. So the way I think of it is sort of cellulitis on steroids. So again, sub-Q thickening. Now you start to get that cobblestoning, and that fluid from the cobblestoning actually starts to track deep, and it starts to kind of thicken up, and it tracks right along that fascial layer. And then the fascia starts to become kind of thick and shaggy and gets irregular. And then you may or may not, depending if it's an air-forming organism, have air. So we'll show you a couple of slides with what sub-Q air looks like. So here is a study from 2013 showing a couple of examples of NSTIs. So the first one here, this is fluid that's tracking kind of deep along the fascial layer. And these stars is actually air. So this is all sub-Q air. So this is a lot of air in here. And air is almost kind of very disorienting. You can't really see anything going on deep to that. The next one over here, this is your fascial layer, has actually gotten super thick. So again, very thickened fascial layer. Here, again, you're just starting to see fluid that's tracking right along that fascial layer. And then finally, same thing. This is, again, your fascial layer that's gotten super thick and shaggy and irregular. There's some fluid deep to it, and then there's fluid on top of it. And again, you get to see your cobblestoning. So coming back to this patient, right, you can see cobblestoning. We see fluid tracking deep. That's sort of layering right on top of that superficial fascial layer, which is thick and shaggy and irregular. And again, there's some fluid tracking below it as well. So this patient actually had an NSTI. Here's another example. Again, fluid tracking along this fascial layer, and right here's the fascia. And then over here, we can actually catch a couple of glimpses of fluid tracking below that superficial fascial layer. So important to realize. This was a study from 2019 that looked at a bunch of cases of NSTIs. And really what they found was the best was your fluid accumulation. And they had used the cutoff of 4 millimeters. And I kind of skipped that one for more of the statistical fanciness that they did. All right, cool. So sub-Q air. So air, like I said, can be a little disorienting in the tissue. So what looks like sub-Q air is going to be bright white with dirty shadowing. So dirty shadowing is essentially gray. So you can see there's these little pockets of bright white, and then there's that gray shadowing underneath it. So again, this is air. And air in anything outside of like your lungs and in intestines does not belong there. So even in an abscess, it's going to be a sign of a more severe abscess. Again, here's another example. Lots of air, right? Because you can see how you just lose any information deep to that. As another example, there was actually so much air in this patient. This was a diabetic gentleman that was found to kind of like altered mental status, febrile, DKA, super sick. He had a wound on his leg that like looked nasty, had like foul smelling, dishwater looking discharge. And this was his leg. And there was so much air, you could just feel the Rice Krispies underneath on the exam. And as we push down, you can see the bright white and the shadowing just kind of shimmering back and forth and moving. So this is all air within this gentleman's soft tissue. He did go on to lose his foot, unfortunately. Here's another example. This was a diabetic gentleman that came in for a week's worth of rectal pain. Also febrile, tachycardic, borderline blood pressure. He was AFib with RVR, kind of sick, was waiting for a couple of hours for a CT because one of those days when we were super backed up. And clinically, he had a very high suspicion for neck fasc. So they had to call surgery. We were waiting for them to come down. And because the CAT scan was taking so long, they didn't want to come down and see him until after the CT was done. And so we went and we ultrasounded him. And again, this is all air. So bright white, lots of dirty shadowing. And as soon as we did that ultrasound, we actually wheeled him straight over to CAT scan. And this was his CT. And again, you can see this poor man had huge amounts of air. So big Fournier's gangrene. So again, he went up to the OR with surgery and urology. So another example, and you can see kind of, there's a little glimpse right here, bright white, and it almost looks like A lines. Like, so if we pause that for a second. So this is an abscess. You can see that fluid collection. There's this posterior acoustic enhancement. And then as we come through, you can see right there. So right here, we have something bright white, and you have this reverberation artifact, right? So it almost looks like A lines from the lung. So again, air in an abscess. Here's another example. So this was a 16-year-old who came in after she had a cow step on her foot a couple of days earlier, went to an outside hospital. They washed it out and they closed it. And so she came in with extending cellulitis. She had a low-grade fever. She had some like bullae, which was kind of black and necrotic looking around the wound. And so we started scanning. And again, you can see that there's definite abscess formation here, right? So there's posterior acoustic enhancement there, but you can see there's a little speck there of bright white. and there, bright white. And so this was air within it. So this was also an NSTI. She ended up going to the OR for a washout. Again, here's another example, also taken from image review. This was a patient also with an abscess on his foot. And when they were scanning, if your eye happens to pick up right there, we can see that bright white with a little bit of shadowing there. So there's some free air here. This white line that pops in right here, that's just not making contact with this, with the skin. Same thing here. This is just not skin contact. All right, so NSTI in summary, cellulitis on steroids. So sub-Q thickening, loss of architecture, cobblestoning, plus that cobblestoning edema starts to layer along that superficial fascial, and then it's more than 4 millimeters in thickness. The fascia starts to become irregular, and then plus minus sub-Q air. So if you see air, you can rule in for NSTIs, but the absence doesn't rule it out. All right, cool. Moving on to abscess. So how do we do it? Again, superficial structure. So you're going to be in your linear probe. Again, please cover your probe because you got cooties on the abscess. So what are my POCUS questions I'm trying to answer? So the first one is there actually an abscess that I'm looking at, or is it a phlegmon? Is it a lymph node? Is it a cyst? Is it a pseudoaneurysm? If it is an abscess, how deep is it, right? So what's the depth of it? What's the extension? And where does that posterior border lie, right? Is it just kind of end here, or is there a little tunnel and I'm looking at maybe an osteomyelitis that's tracked to the surface? And then what structures are around it? Is there an artery laying right on top of it where it might not be such a good idea to cut into it? Also very important things to know. So what does an abscess look like? Again, it's going to be hypoechoic, so it's going to be darker than the stuff around it. And then anything that's fluid filled, right, is going to have posterior acoustic enhancements, where we spent the time learning our artifacts. One of the most important things you're going to look for is what we call the squish sign. So just like it sounds, you're going to take your probe and you're going to squash it down, and you're going to look to see that pus sort of go back and forth. We call it pus stultus. And generally, you'll see some sort of surrounding edema or cobblestoning, again, kind of sign of surrounding infection. And then finally, you always want to throw a Doppler on it to make sure that you are not cutting into something vascular by accident. Cool. So the simple abscess. So here you can see hypoechoic. There's a clear collection to the area. You can see that posterior acoustic enhancement, and you can clearly just see the defined posterior wall. So here's another example. This person should have used a little bit more depth so we can figure out how deep this abscess goes. But again, you can see irregular, it's hypoechoic, there's posterior acoustic enhancement. Other important things for this abscess, right? So if I scan this thing is huge. This is probably a pilonidal. But if I cut into it and I get almost nothing out, that's going to tell me I'm either not deep enough, I didn't make my incision big enough, or I'm not over the area of pus. So ultrasound can also help you localize the area of maximal pus from where to cut. Here's another example. So this one is a little more kind of tissue dense looking. And so you might scan over it and say, oh, there's nothing to drain. This looks pretty solid to me. But if you notice when they give a little compression, you can see that there's a little bit of movement here. So this is actually fluid filled. And if you notice, there is posterior acoustic enhancement. Here's another example of the same thing. So this is pretty irregular. It's not kind of walled off and defined, but you can see that this is purulent material. And when they push down, you can see that pus is sort of squeezing and squashing and getting pushed around. So again, may not necessarily pop out to you right away as like an obvious abscess, but that squish is going to be super important to help you realize that this does need an IND. This one was not from this ER, but a gentleman who was a diabetic who had stepped on a sewing needle a couple weeks earlier, who came in with pain and swelling in the foot, and it looked like an abscess. So they stuck an ultrasound probe on it, and this is what they saw, right? So a tiny little abscess. But if you notice when they push down, you can see that pus is kind of tracking, but it's tracking deep. And there's like a little stalk to this thing. And where it actually communicated with was the heel and the calcanea. So this was an osteomyelitis. This case was from our ER here. This was a gentleman who had had a shoulder replacement done a couple of years ago, who had come in with what looked like an abscess, kind of not exactly on the suture line of where his surgery was, but kind of next to it. And so we just were doing educational scanning rounds and had plopped the probe on, and this is what we saw. And you can see that abscess right? Actually tracking all the way down to that bone. And if you notice, the bone's kind of raggedy and jagged and kind of interrupted, and there's a little bit of a discontinuity of the cortex. And so this was actually a osteomyelitis with a hardware infection. So the patient ended up going to the OR with orthopedics. The other important thing, right, is to look at how deep is this abscess and what is it sitting in. So this is an intramuscular abscess. So again, not something that I'm going to be cutting into. Patients may come in with like kind of atraumatic extremity pain. And so sometimes you may just kind of be scanning through them just to see if there's anything going on. And so lo and behold, you might find something. All right, so some quick pitfalls. So lymph nodes are going to be a good fake out, right? So it's going to be hypoechoic. It's going to be kind of clear, distinct borders. There's a little bit of posterior acoustic enhancement. But when you push down, right, you can clearly see this is sort of solidy. It doesn't sort of wiggle and move like pus or a fluid filled. So again, don't want to cut into these. Definitely have done that, my fair share of that in residency. Here's another one, right? This looks pretty classic for an abscess. It's irregular, it's hypoechoic, there's kind of clear defined margins, but there's a couple things that's going to clue you in. One, there's something vascular right here, so I'm always going to second guess wanting to cut into these. And then two, I throw color flow on, and you can see that there's a large amount of vascularity to this thing. And so again, you do not want to IND this. This actually was a suppurative lymphadenitis, so this was an infected lymph node. Here's another example. This was an elderly gentleman who came in with like a red swollen groin that looked really infected. We put the probe on because we thought maybe it was an abscess. We saw this, right? It looks kind of something pus filled. And then we come here and we see it looks like a stalk. And there is lots of vascularity when we throw color flow on it. And so this was actually a ginormous lymph node. This was a gentleman who came in with cellulitis on his thigh, and we were scanning through, looking for signs of NSTI. You can see that it's thick, and there's a lot of homogeneity. And lo and behold, we found this thing, and we were like, is that an abscess? I'm not sure. We did some squish and some compression, and it didn't really compress, but I was like, that's definitely not a lymph node. So we threw some color flow over it, and you can see there's some internal vascularity to this thing. And this was actually a superficial venous thrombosis. All right, cool. So some tips. So make sure that you are extending your depth to look at that posterior wall to figure out where that abscess kind of ends and make sure it doesn't have a stalk communicating somewhere. Always throw color flow on it to make sure that it's not something vascular. Make sure you're looking at the deeper structures that's around it. Again, give some compression, look for pus, and make sure you're doing that squish test. And then high risk areas you want to look at is anything in the head and neck, anything in the axilla, because you're going to get your armpit, lymph nodes. Inguinal region, right? You can get vascular stuff. AV fistulas, although I don't think anyone's dumb enough to try to IND an AV fistula. And then prior surgeries. So you may be looking at seromas or hematomas, which brings us to hematoma. So a hematoma sonographically looks like an abscess. Very difficult for us to tell the difference. And it can be sub-Q or intramuscular. So this was a gentleman who had had a cath procedure who had come in a couple days later with what looked like maybe a pseudoaneurysm. We weren't sure versus an abscess. We threw the probe on, and you can see that there's this kind of clear linear line. And so this is clotted blood with some fresh blood in there. So this was a hematoma. This was a gentleman who started exercising and did a crap ton of sit-ups and then came in with really sore abdomen where he was kind of focally tender and he had some swelling that he had noted. So we did our ultrasound, and this gentleman had given himself a rectus sheath hematoma. This was another hematoma. So this was a knee. Actually, this was a little old Nana that had fallen right on a bent knee. And her knee was sort of like blowing up in front of our eyes while we were scanning her. It was crazy. And so we throw a probe on, and you can see the active extravasation from a broken blood vessel coming right into this hemarthrosis that she is developing. Cool, which brings us to joints. So we can look at knees, and I love ultrasounding joints, especially if there's a surrounding cellulitis that crosses a joint line, because really what I want to know clinically is, am I looking at a septic joint and do I need to tap it? And if I have to tap it, what's likely my success rate? So if there's no effusion that I see on ultrasound, I'm not going to tap it because I'm not going to get any fluid out, right? But if I see fluid, and there's surrounding cellulitis. Well, now I'm very concerned for a septic joint. Cool. So again, you're going to be in long axis. We're going to move from the thigh into the center, right down the knee. You're going to get your bone right in nice where it's kind of crisp and clear. And then I'm just going to pause that for a second. Cool. So here again, that's my femur. Here's my patella. You can kind of see, not super clear, but this is the quadriceps tendon. And then here's the quadriceps down here. So if there's an effusion, right, the suprapatellar space communicates with your joint. So an effusion, you're going to see black. That's going to live right where this yellow triangle is. So again, here's an example of an effusion. And if you're not sure, again, you can compress and that effusion is going to push out and squish in. So again, here's femur, here's effusion, and then there's patella. So they've done studies trying to look at the characteristics of the effusion, the rind thickness of like the synovial lining, if there is complexity into the effusion, trying to figure out if it's septic versus arthritis versus gouty, and nothing has been proven sonographically. So the only way to tell is actually to sample it. All right. So next one that's really easy to look for effusion is going to be the ankle. Again, start in long axis, and you're going to come down. You're going to find the tibia. That space where it drops off is going to be your joint right here, and here's your talus. So again, there's your tibia. We're coming down, drops off. Here's the ankle space, and then there's my talus. So if there's an effusion, again, you're going to see black. That's going to be distending this area. So same thing. So here's an effusion right there. So again, if this patient came in with a red swollen ankle, it hurt to walk, and it looked like maybe cellulitis, and I ultrasounded them, and this is what I see, right? They need a tap. All right, cool. So some quick tips. Always compare to the unaffected side if you're not sure. So it's going to help you to figure out if there's an effusion or not. And then my general rule of thumb is if there's a surrounding cellulitis over a joint, always ultrasound it to figure out if you need to tap the joint or not. All right, cool. So quick summary. Cellulitis, you got your sub-Q thickening, your loss of architecture, and your cobblestoning. Your NSTIs are cellulitis plus. Your fascial thickening, the fluid collection starts to track deep along that fascial layer, and it's going to be more than 4 millimeters in thickness, and you're going to see sub-Q air plus minus. When you have an abscess, make sure you're doing your squish sign, so make sure you're not getting faked out by lymph nodes and cysts. Make sure you throw Doppler on it to not accidentally cut into something vascular. Look for that posterior acoustic enhancement, and look to see sort of where that posterior wall ends of your abscess to make sure that you are not looking at something that's more complex. For when we look at bones, look at your joints to evaluate for effusion. You can also look for dislocations. You can see fractures. I know we didn't cover that on the bones. And you can use it for ultrasound-guided arthrocentesis to help guide that needle right into that joint space. All right, that's all I got. Thank you guys for putting up with us. I super appreciate it. I'm going to stop my share. Bear with me for 2 seconds. Stop sharing. All right. Thank you guys so much. I hope you have lots of ultrasound success and keep us in mind. And I hope you enjoy the Training Academy. If you have any feedback, please send it my way. We're going to do this again probably in January, February. And so any feedback that you have will just kind of help improve this program for like the next cohort. Awesome. Thank you guys. Have a good night.